Hello. So now we are going to see about chelating agents. So chelating comes from the Greek chele, that means crab. So these agents like a claw of the crab. So this is the claw of the crab. Like the claw of the crab, they will hold into the molecules like this. The claw, so they will hold it inside. So this is how chelating agents got their names. These are primarily used in heavy metal poisonings. These are useful agents that have hold up to 5 to 7 members of the group. Heavy metal, how heavy metals will exert their toxicity? They will exert the toxicity by combining and inactivating the functional groups of the body. So what these chelating agents do? They have a better affinity towards the toxic metal. They will go and bind with the toxic missile. So there, what are the features that they should have? So they should compete with the body ligands for heavy metals. They should differ in their affinity for different metals. Clinically useful agents should have a higher affinity for the toxic metal than for calcium, because calcium is readily available in the plasma. So if it doesn't have the affinity, it will go and bind with the calcium, so which may again cause acute calcium depletion, and in long term, which may cause bone defects like osteoporosis. So chelating agents should have a higher affinity than the body ligands for toxic metals. The distribution should correspond to that of the metal to be chelated, and they should be water soluble, of course. So the most common chelating agents that we have are, that is dimercaprol or British anti-Lewiston, that is BAL. And I have dimercaprosuccinic acid, disodium intermediate, calcium disodium intermediate, and calcium disodium DTPA, penicillamine, desferoxamide, and defriprone. So next, so over here I have dimercaprol or British anti-Lewis. So talking about it, it is a oily, pungent smelling viscous liquid that was developed during the World War II by the Britishers as an antidote to the arsenic war gas Lewist. So what was it? Lewist was a war gas. So it was developed by the British. So British anti-Lewist or BAL, dimercaprol. So we can see the structure over here. So what happens? The these two SH group, they will bind some metal, and thus they will provide us the chelating effect. So what will happen? Over here they will bind a metal and will provide the chelating effect. So that's how this works. Now talking about this, there are 1:1 complex and 2:1 complex that can be found with dimercaprol and the agent. So the metals can be arsenic, mercury, gold, bismuth, nickel, copper. So these are the metals that can be used, and to this we need a 2:1 complex which is more soluble than the 1:1 complex. So we'll prefer the 2:1 complex to be formed, which is easier, more stable, and it is easily formed. So we have to make sure that the excess of dimercaprol is there in the plasma always. And the thing is also in antimony poisoning. So next, dimercaprol complex will dissociate spontaneously in the urine, and it will release metal in a slow rate. So it is more favorable to excrete out this in the acidic urine. What happens in acidic urine is the metals will spontaneously degrade. So while giving this, we will give alkaline urine. Alkalinization of the urine is done so that this is prevented. So uses in the toxicity, then second uses toxicity of the arsenic, mercury, gold, bismuth, nickel, and Sb, that is antimony. Then adjuvant to calcium disodium intermediate in case of lead poisoning, and adjuvant to penicillamine in copper poisoning. Another thing to note is dimercaprol is contraindicated in iron and calcium poisoning, because dimercaprol iron, dimercaprol cadmium complex itself is very toxic, so we don't do that. So next I have disodium intermediate. So I would like to see the structure intermediate. What happens intermediate is this sodium, this is not there. Intermediate is ethylene diamine, the ethylene diamine tetraacetate, CH2CO, CH2CO, tetraacetate. This is a disodium salt of EDTA. It is acidic in nature. So, and what happened, another thing is we can replace one of the hydrogen over here, say for example with calcium. So you're getting calcium disodium intermediate. So both of them have almost similar range of action. So what is disodium intermediate? It can cause, the first one, that is disodium intermediate. This can cause acute calcium poisoning in the body. So what it does is, it cause hypercalcemia. How? Used in the treatment of hypercalcemia. How? Because the sodium will go out and it is a good way to chelate the calcium. So it can chelate calcium. So next, talking about calcium disodium EDTA, it is the calcium chelated. So over here, one of the hydrogen, it will go away and calcium will come. Instead of OH group, we'll have a calcium. So it is calcium chelated over this. So this is the structure somehow. So what it does is it is used in lead poisoning, and it is used in case of iron, zinc, copper and magnesium and radioactive poisoning, but not in case of mercury poisoning. Why? So what happens in case of mercury poisoning is mercury is firmly bound to the body constituents and localized in the areas that are not accessible to this. Another thing to note is this is very water soluble and the elements are water. So we give two treatments. First, whatever is there in the body and the toxicity, that is removed in the first treatment. After say certain times, say week, 2 weeks, 5 to 7 days, the second treatment is given. The thing about second treatment is do this so that whatever after the treatment came back, right, that can be easily treated out. That is, it is water soluble. The metal will be in extracellular spaces. We can't access that compartment. So yes. Next, we shall be seeing penicillamine. So penicillamine, we use the D isomer of the penicillamine. Talking about penicillamine and the D isomer of penicillamine, use the D isomer because the L isomer and the racemic mixture, they are toxic after oral absorption, and so we give the D isomer. So what it does, it is a dimethylcysteine obtained from degradation of the product of penicillin. This is very good for copper chelation. So it is given in the treatment of Wilson's disease, which is caused due to deficiency of ceruloplasmin, which is an intrinsic copper carrier present in the body. As ceruloplasmin is deficient, so what will happen is the toxicity will increase in the body. As the toxicity will increase in the amount of copper in the body will increase, it will give me toxicity. Sign like we have a brownish discoloration ring present in the eye in case of Wilson's disease. That is the fair line. It is a ring structure that is present in the body in case of copper deficiency. That is a different thing. Secondly, in mercury poisoning and chronic lead poisoning, along with the adjuvant to calcium disodium EDTA, it can be given. Next, I have desferoxamine and deferoprone. What about these are deferoprone, desferoxamine, and defacirox? These three. Okay, defacirox I have not mentioned here. I will mention it. So I'll just mention it, right? Defacirox, right? So what these three? These three are yes. So I mentioned here. You can see. So these three are mostly used in iron poisoning. They are made of iron also. So talking about ferroximine is a long iron chain containing a complex compound. It is obtained from actinomycete, that is a fungi, and it is used in the removal of iron from the desferoxamine. It has a very high affinity for iron. That is 1 gram of this is able to chelate 85 mg of iron. Desferoxamine removes loosely bound iron from hemosiderin and ferritin, but not from hemoglobin or not from cytochrome. Another property is it has very low affinity for calcium. This one. Parenterally administered, it is partially mobilized and rapidly excreted in urine, used in iron poisoning. Adverse effect, it can result in histamine release and fall of BP, flushing, urticaria, rashes, like most of hypersensitivity, that is type 1 hypersensitivity allergic reaction, which can be managed with antihistamines, not an issue. So defriprone, it is an orally active iron chelator, and yes, so it is less effective than desferoxamine, and it facilitates removal of iron load in hepatic cirrhosis and other indications. Side effects are anorexia, vomiting, nausea, joint pain, and desferox, which is another orally active iron chelator which lowers serum ferritin and hepatic iron in patients. So I will say a thing about all three of these in common. That is, all three of them they are used in case of person with hemolytic blood disorders. So what happens in case of hemolytic blood disorder is we give the patient blood. As we give the patient blood, we are just giving the patient a lot of blood, and hemolysis will occur. When hemolysis will occur, the iron content in the blood will increase. As the iron content in the blood will increase, we will have iron toxicity. So, and iron overload. So to reduce this iron overload and iron toxicity, we are giving. So what I'll give you a list, a few cases, right? So you'll see thalassemia. What happens in thalassemia? I have to give repeated blood transfusion to the patient. As I'm giving repeated blood transfusion, there will be iron overload. As iron overload is occurring, it will cause acute side effects. So to prevent this acute toxicity, I am giving deferiprone or deferosix, or I can also give the desferoxamine. These three are there. Next, talking about deferosix, talking about it specifically, it is used what trace elements like copper and zinc. It is well absorbed orally. This deferox, this is well absorbed orally. Yes, so that's what.